Welcome to our video on demyelinating disease. Let's get started. Here are the disorders that we'll cover in this lecture. For each of the demyelinating disorders, we'll cover definition, pathophysiology, risk factors, clinical presentation, diagnosis, and management. Let's begin with a brief refresher on the role of myelin in the nervous system. This image depicts the structures of a neuron. From your preclinical years, you'll remember that the axon is typically the longest part of a neuron that transmits the electrical impulse from the cell body to the axon terminal. Axons are covered in myelin to speed up the conduction and prevent dissipation of electric impulses. In the central nervous system, axons are myelinated by oligodendrocytes. In the peripheral nervous system, axons are myelinated by Schwann cells. Each of the disorders that we'll discuss in today's lecture disrupts the myelin sheath in neurons, leading to demyelination of those neurons, and various neurological symptoms. Let's begin with multiple sclerosis. Multiple sclerosis is a demyelinating disorder of the central nervous system. The disorder primarily affects the white matter of the brain and the spinal cord. So, multiple sclerosis, think brain and spinal cord. The exact etiology of multiple sclerosis is unknown. The traditionally accepted hypothesis is that it's a combination of genetic, environmental, and immunologic factors, and that results in destruction of myelin in the central nervous system. In other words, an environmental trigger causes an autoimmune reaction in a genetically predisposed individual. The disorder affects nerves seemingly at random, causing neurological symptoms which really can't be explained by a single lesion. There are several high-yield risk factors for multiple sclerosis that you need to know for the boards. The classic patient in almost every vignette will be a young Caucasian woman who lives far away from the equator in places like Europe or the United States of America. In fact, women are 2 to 3 times more likely to have multiple sclerosis than men. Similarly, the prevalence of multiple sclerosis increases with increasing distance from the equator. This is thought to be a result of genetic predisposition within populations that traditionally lived far away from the equator, as well as decreased exposure to sunlight, which can lead to vitamin D deficiency. Vitamin D, turns out, plays a role in modulating the innate and adaptive immune responses. Over the past decade or so, we've learned that vitamin D deficiency is associated with increased susceptibility to infections, as well as increased risk of developing an autoimmune disorder, such as multiple sclerosis. Other testable risk factors include HLA-DRB1, smoking, and an EBV infection. The evidence for these 3 risk factors comes from robust epidemiological studies that have noted a statistically significant association between these risk factors and multiple sclerosis. Now, HLA-DRB1 simply increases one's genetic predisposition to multiple sclerosis. Now, smoking is known to affect the function of T cells, B cells, and natural killer cells, which have an important role to play in the course of multiple sclerosis. On top of that, tobacco smoke itself contains nitric oxide and cyanide, which can exacerbate demyelination. Now, the role of EBV in multiple sclerosis is complex, but the overall theme seems to be that EBV infection decreases the threshold for activating autoimmune T cells in response to health events that come later in life. Patients with multiple sclerosis classically present with recurrent neurological symptoms that are separated by space and time. That's important to remember. In other words, they may have recurrent episodes of transient sensory deficits, fatigue, or motor symptoms that resolve within a few weeks, only to come back several months later, or even years later. So, separated by time. Additionally, the range of symptoms is usually wide enough that it's hard to explain all of them by a single lesion in the central nervous system, so separated by space. Now, several clinical manifestations of multiple sclerosis are particularly high yield for the boards and deserve a special mention. Lermit sign describes a sensation of an electric shock going down the spine, typically upon flexion of the neck. Uthoff phenomenon describes worsening of symptoms of multiple sclerosis in hotter environments. In fact, on exams, you may be given a case of a patient moving from a colder area, such as Minnesota, to a much hotter area, such as Arizona, and suddenly experiencing worsening of symptoms. So that would be Uthoff phenomenon. Alternatively, test writers may present a vignette in which patient symptoms are getting worse when taking a hot bath. Now, bilateral trigeminal neuralgia should always raise suspicion for multiple sclerosis, as multiple sclerosis is the most common cause of bilateral trigeminal neuralgia. Most other causes are unilateral. Transverse myelitis may be the presenting symptom of multiple sclerosis on your exams, so it's worth remembering that association as well. Lastly, multiple sclerosis is associated with two high-yield visual pathologies that warrant a more thorough discussion. Those two pathologies are optic neuritis and internuclear ophthalmoplegia. Optic neuritis is a painful unilateral vision loss due to immune-mediated demyelination of the optic nerve. Patients may report abnormalities in their color vision, typically described as washed-out color vision, or red color desaturation. Additionally, patients may report seeing a black spot in the middle of their vision, often referred to as central scotoma. Optic neuritis has a very high-yield physical exam finding called relative afferent pupillary defect, which we'll discuss in more detail shortly. So just keep that in the back of your mind, and we'll really show you how that works. Now, optic neuritis is diagnosed with MRI of the brain and orbits, and it's treated with high-dose IV steroids. Oral steroids, generally speaking, are not preferred in the treatment of optic neuritis, so think of IV steroids. A 30-year-old female with a history of multiple sclerosis presents to your clinic with concerns of double vision. When asked to look to the right, her left eye is not able to move past the midline, and there is notable nystagmus visible in the right eye. What is the likely diagnosis? This is a classic description of internuclear ophthalmoplegia, or INO. In this case, it's left-sided INO. Now, this finding is particularly high yield for the boards, so let's take a minute to ensure we understand it. Internuclear ophthalmoplegia is a visual disturbance seen in multiple sclerosis when there's a lesion in the medial longitudinal fasciculus. Recall, the medial longitudinal fasciculus is a heavily myelinated collection of neurons that coordinates and synchronizes the horizontal movement of our eyes. Each eye has its own medial longitudinal fasciculus that allows for fast communication between cranial nerve 6 and cranial nerve 3, meaning both eyes can move to the right and left on the horizontal plane in tandem. When there's disruption on a medial longitudinal fasciculus, the horizontal eye movements become desynchronized, which leads to diplopia or double vision. And that makes sense, because if both eyes aren't looking at the exact same spot, but are looking at two different areas, then patients are going to have diplopia. Unfortunately, regarding INO, diplopia is not the only symptom commonly tested on exams. You should know that a lesion in a medial longitudinal fasciculus would specifically lead to inability to adduct the ipsilateral eye and nystagmus on abduction, abduction, of the contralateral eye. Now, the test writers often confuse students by listing the left medial longitudinal fasciculus as well as the right one as possible answer choices. But let me make this very simple for you. If a patient cannot adduct the left eye, it is the left medial longitudinal fasciculus that is lesioned, and the patient would therefore have left INO. On the other hand, if a patient cannot adduct the right eye, it is the right medial longitudinal fasciculus that is lesioned, and the patient would therefore have right INO. To drive this concept home even further, let's use a visual guide to illustrate right-sided INO. Here's a pair of eyes, each innervated by their own cranial nerves 3 and 6, which are connected by a medial longitudinal fasciculus. If we were to ask a person with healthy eyes to look either right or left, both eyes would move in synchrony. Nothing surprising here. It's normal. Now let's see what happens in case of internuclear ophthalmoplegia. Suppose we lesion the right medial longitudinal fasciculus in this person, and we ask the patient to look left. Their left eye will look to the left as expected. But we would be able to appreciate notable nystagmus on full abduction, abduction, of the left eye. Their right eye, in contrast, will not be able to move past the midline when trying to look to the left. In other words, this person will not be able to fully adduct or adduct their right eye because their right medial longitudinal fasciculus is lesioned. If we were to ask this person to look to the right, on the other hand, their eyes would move in synchrony, as expected. To reinforce the point from the previous slide, always pay attention to the eye that cannot adduct, adduct. And by focusing on just that eye, you can localize the INO. If it's the right eye that can't adduct, this means the person has a lesion in the right medial longitudinal fasciculus and has a right internuclear ophthalmoplegia. That's the case in this image. And if it were the left eye that couldn't adduct, the lesion would be in the left medial longitudinal fasciculus, and the person would have a left INO. Okay, with that background, let's move on to diagnosis. Multiple sclerosis is a clinical diagnosis, and it should be considered in young adults with relapsing and remitting neurological symptoms. But you can confirm it with an MRI, CSF analysis, or even using evoked potentials. Though each of these diagnostic modalities will be abnormal in about 90% of patients with multiple sclerosis, MRI is still considered to be the most sensitive test. Classically, it will reveal periventricular demyelinating plaques, or areas of demyelination next to the ventricles in the brain. And we'll see an image of this shortly. Now, analysis of the cerebrospinal fluid will reveal oligoclonal bodies, and that's a particularly high-yield term for the boards. Lastly, question stems may often describe abnormal evoked potentials to hint at a diagnosis of multiple sclerosis. In short, an evoked potential test measures the time it takes for nerves to respond to stimulation. Recall that in multiple sclerosis, we observe demyelination of neurons. Due to the loss of myelin, the electrical signal will travel slower through the neurons of patients with multiple sclerosis. And you can capture that slowness using a device which would subsequently report an abnormal evoked potential. The evoked potentials mentioned on exams are typically either visual or auditory. Visual evoked potentials are elicited by having a patient look at a specific pattern. Auditory evoked potentials, on the other hand, are elicited by having a patient listen to a specific auditory tone. Here's a classic example of MRI findings in patients with multiple sclerosis. And here are the ventricles. And next to them, we see multiple demyelinating plaques, or lesions. For your exams, you'll be expected to identify these plaques and recognize their association with multiple sclerosis. Now let's talk management. Management of multiple sclerosis is generally broken down into three main components. Acute flares are managed with high-dose IV steroids as a first-line option, followed by plasma exchange or IVIG as second-line options. Chronically, multiple sclerosis can be managed with many disease-modifying drugs. The three drugs that are particularly high yield for the boards are interferon beta, natalizumab, and glatiramer. On a side note, you should know that interferon beta may cause patients to experience flu-like symptoms and severe depression. You should also know that natalizumab can cause reactivation of the JC virus and thus lead to progressive multifocal leukoencephalopathy, or PML. As such, all patients who need to be started on natalizumab must be screened for the JC virus first. Now, unlike the other two drugs, glatiramer doesn't have particularly high-yield side effects. When it comes to general symptom control, you should know that spasticity is typically treated with baclofen or dantrolene, and that trigeminal neuralgia is treated with carbamazepine as a first-line treatment. Now, all patients with multiple sclerosis should be screened for depression and treated appropriately with CBT, cognitive behavioral therapy, or first-line medications such as SSRIs or SNRIs. Okay, here's the overview slide again. Let's now talk about acute disseminated encephalomyelitis and progressive multifocal leukoencephalopathy, or PML, next. Acute disseminated encephalomyelitis, or ADEM, is a disorder similar to multiple sclerosis, except it causes encephalopathy and it does not cause chronic disease. In other words, you can think of ADEM as a one-time multiple sclerosis with encephalopathy. It's worth your time to know that demyelinating plaques in the thalamus are more suggestive of ADEM than multiple sclerosis. Recall, multiple sclerosis typically leads to periventricular demyelinating plaques, where ADEM is typically preceded by infection or immunization, and it's treated with IV steroids, which is very similar to how you treat the acute flares in multiple sclerosis. Progressive multifocal leukoencephalopathy, or PML, is a demyelinating disorder of the brain affected with JC virus. So they were once infected with that, and then there's subsequent reactivation. Now what happens is this. The JC virus infects oligodendrocytes in the central nervous system, and it's normally kept at bay by the host's immune system. But if the host becomes immunocompromised, however, JC virus may reactivate and cause PML. And we just mentioned a drug that can cause that immunosuppression, which is natalizumab. Hence, the risk factors for this condition are all centered around immunosuppression. In fact, most often the clinical vignettes will be about patients with HIV who have a CD4 count of less than 200. And you should also know that natalizumab and rituximab are two drugs that are associated with JC virus reactivation, and those can sometimes show up on tests, so lock that one away. Clinically, this condition will present with slowly progressive neurologic symptoms, such as confusion, ataxia, seizures, and weakness. Now, PML can be diagnosed with MRI of the brain, which will show demyelination in the white matter of the brain, or analysis of the cerebral spinal fluid, which will be positive for the JC virus. Unfortunately, this condition is often fatal, and there aren't many treatment options really. However, if you diagnose PML in a patient with AIDS, you can treat them with antiretroviral therapy. A 35-year-old woman with a history of multiple sclerosis is brought into the emergency department by her husband after new onset seizures, followed by loss of consciousness. He says she's been experiencing progressive confusion, weakness, and problems with coordination over the past several weeks, after starting a new medication for multiple sclerosis. He says she's never had neurological symptoms to this extent in the past and was doing well prior to starting the new medication. What is the most likely diagnosis? Well, the vignette describes worsening of neurological symptoms in a patient with multiple sclerosis following initiation of a new medication. Since the patient was doing well prior to initiation of the medicine, it is unlikely that she had an acute flare of multiple sclerosis or required additional therapy for symptomatic management. Hence, she was most likely initiated on a medicine aimed at controlling the chronic course of her disease. Now, examples of such medicines discussed in this lecture are interferon beta, glatiramer, and natalizumab. As mentioned earlier, interferon beta is associated with flu-like symptoms and severe depression, which she's not really experiencing here. Glatiramer, for your purposes, doesn't really have any high-yield side effects you need to remember. Natalizumab, on the other hand, has a potential for causing progressive multifocal leukoencephalopathy, which is likely the explanation for her worsening neurological symptoms. Here's the overview slide again. Let's conclude this lecture with a discussion on Guillain-Barré syndrome. Guillain-Barré syndrome is an autoimmune inflammatory demyelinating polyneuropathy, and it affects the peripheral nervous system. In other words, the immune system attacks many peripheral nerves, leading to loss of the myelin sheath on them, which in turn leads to neurological symptoms. Notably, this is in direct contrast to the first three disorders we discussed in this lecture, all of which affected the central nervous system. Now, there are many variants of Guillain-Barré syndrome, but the three variants to know for the boards are acute inflammatory demyelinating polyneuropathy, or AIDP, chronic inflammatory demyelinating polyneuropathy, or CIDP, and Miller-Fisher syndrome. AIDP is essentially synonymous with Guillain-Barré syndrome, as it's the most common variant. Hence, for the purposes of the boards, you should think of Guillain-Barré syndrome and AIDP as terms that can be used interchangeably by the test writers. As with most autoimmune disorders, Guillain-Barré syndrome is thought to happen when an environmental antigen triggers an autoimmune response in a genetically predisposed individual, and that response is against a particular target in the body, and in this case, the myelin sheath of the peripheral nerves. The destruction of the myelin sheath leads to neurologic symptoms. The two primary risk factors for Guillain-Barré syndrome are recent infection or immunization. Notably, a recent Campylobacter jejuni infection, a viral infection, or influenza vaccination are particularly associated with Guillain-Barré syndrome. Clinically, Guillain-Barré syndrome presents as ascending, symmetric weakness or paralysis, and areflexia. Now, the ascending pattern weakness is in contrast to the descending pattern of weakness that you'd see in botulinum toxin. Now, the symmetric nature of the ascending pattern of weakness is in contrast to the asymmetric ascending weakness seen in polio. Remember, polio is very asymmetric, but this is symmetric. Hence, pay careful attention to the pattern of weakness in this disorder. If the disorder ascends to the level of the diaphragm, patients may experience respiratory arrest, which would necessitate ventilatory support in the ICU. So keep that in mind. Just be thinking in the back of your mind, if you see this Guillain-Barré patient, be worried about their lungs and respiratory arrest. Additionally, patients may sometimes experience dysautonomia, or dysregulation of the autonomic nervous system. This can lead to a wide range of symptoms, such as constipation, large swings in heart rate or blood pressure, and other bodily dysfunctions that are normally under the control of the autonomic nervous system. Lastly, patients with Guillain-Barré disorder may also report paresthesias, or abnormal sensations. Now, Guillain-Barré syndrome is a clinical diagnosis that can be supported by findings on analysis of CSF and nerve conduction studies. Now, CSF analysis would reveal a phenomenon known as albuminocytologic dissociation. This is when CSF protein is increased, but the cell count actually remains normal. Hence, there is a dissociation between albumin count and the cell count. Now, nerve conduction studies would reveal decreased nerve conduction velocity. This is because demyelinating disorders, like Guillain-Barré syndrome, slow down the conduction of nerve impulses. As a side note, you should know that nerve conduction studies can help you distinguish disorders that affect nerve axons from disorders that affect the myelin sheath. As we just mentioned, demyelinating disorders will exhibit decreased nerve conduction velocity. But disorders that lead to destruction of nerve axons, on the other hand, will not exhibit a change in nerve conduction velocity during those nerve conduction studies. Instead, axonal lesions will cause a decrease in the amplitude of the graph generated from nerve conduction studies. So again, in Guillain-Barré syndrome, a nerve conduction study would just show a decreased velocity, but an axonal lesion would show decreased amplitude. A 25-year-old female presents to the emergency department after sudden onset weakness in her right leg. She says she went out camping over the weekend with friends. Physical exam of the right lower extremity is notable for 0 out of 5 strength and Achilles reflexes. What is the next best step? You may be tempted to diagnose this patient with Guillain-Barré syndrome based on our discussion just a few minutes ago. Well, if you've paid close attention, you probably linked her recent camping trip to a potential exposure to Campylobacter jejuni, which is strongly associated with Guillain-Barré syndrome. However, you probably also noticed that her weakness is not symmetric as one would expect in this case. So what's that all about? Well, this, in fact, is a typical vignette for a case of tick-borne paralysis. Tick-borne paralysis occurs when a tick attaches to an unlucky camper and causes, essentially, an asymmetric variant of Guillain-Barré syndrome. Hence, the next best step in this situation would be to look for a tick, and if found, carefully remove it with a pair of tweezers. The symptoms will resolve. It's a super strange condition. Now back to Guillain-Barré syndrome. Let's talk about the management. You should know that Guillain-Barré syndrome is pretty much a self-resolving condition. The primary goal of clinicians is to help the patient get through this disorder alive. Now, first-line treatment includes IVIG and plasmapheresis. Both of these are designed to tame down the immune system, giving the patient's peripheral nerves a chance to remyelinate. Of course, if the disorder ascends all the way up to the diaphragm and the patient is no longer able to breathe on their own, a clinician would have to transfer the patient to the ICU and initiate ventilatory support. Now, because of this potential for respiratory arrest, patients with Guillain-Barré syndrome require frequent monitoring of their breathing capacity. This is often done by monitoring the negative inspiratory force and vital capacity. Now, once patients begin to recover, physical therapy and rehabilitation can be helpful in helping them return to their normal functional levels. Now, you should know that steroids are not helpful in treatment of this disorder, and thus would be an incorrect choice on the test. And that's unusual because in most of the disorders we've discussed in this lecture, steroids are helpful, but not here, not with Guillain-Barré syndrome. Lastly, even though this disorder is technically self-limited, recovery may take up to a year. That being said, 85% of patients will make a complete or near complete recovery. Now, chronic inflammatory demyelinating polyneuropathy, or CIDP, is basically Guillain-Barré syndrome that lasts more than 2 months. So where Guillain-Barré was acute inflammatory demyelinating polyneuropathy, this is chronic, so more than 2 months. Now, how do you treat it? Well, you treat it with IVIG, plasmapheresis, and unlike Guillain-Barré syndrome, you can give steroids. Miller-Fisher syndrome is a variant of Guillain-Barré syndrome that is characterized by a triad of external ophthalmoplegia, ataxia, and areflexia. It's associated with anti-GQ1B antibodies, and its management is similar to Guillain-Barré syndrome. Now let's conclude this presentation with a practice question. A 43-year-old woman comes into clinic with chief complaints of weakness and double vision. She says her symptoms first started several weeks ago and have gotten progressively worse. She denies having similar symptoms in the past, and that she has been healthy her whole life. She says she always had good primary care follow-up and even received her flu shot about a month ago. She denies pain with eye movements. She does not take any medications. Vital signs are within normal limits. During a physical examination, the patient is unable to adduct the left eye and unable to abduct the right eye. Sensation to vibration and pinprick is intact throughout. Strength is 5 out of 5 in upper extremities and 2 out of 5 in lower extremities bilaterally. Patellar and Achilles reflexes are absent bilaterally. Analysis of the cerebrospinal fluid is most likely to reveal which of the following: A. Elevated white blood cell count, normal protein levels. B. Elevated white blood cell count, elevated protein levels. C. Normal white blood cell count, normal protein levels. D. Anti-GQ1B antibody. Or E. Oligoclonal bands. Now the correct answer here is D. Anti-GQ1B antibody. You most likely narrow down the differential to either multiple sclerosis or a variant of Guillain-Barré syndrome. So let's parse this question further to distinguish between the two. In this vignette, we're given a patient with recent onset neurologic symptoms following a recent episode of immunization. Recall that immunizations, particularly the influenza vaccine, are associated with Guillain-Barré syndrome and its variants, and she had her flu shot about a month ago. Next, notice that she hasn't experienced neurological symptoms in the past, so we don't have the typical symptoms of multiple sclerosis that are separated by time and space. So far, onset is more suggestive of Guillain-Barré syndrome. Next, let's consider her symptoms, starting with her ocular symptoms. If we're considering multiple sclerosis as the underlying diagnosis, we should consider possibilities of internuclear ophthalmoplegia and optic neuritis. Now, optic neuritis is unlikely in this case because she doesn't report vision loss and denies eye pain. Now, INO is also unlikely in this case because it doesn't lead to problems with abduction of the eyes, which she does have a problem with. Yet she can't abduct the right eye. Note how, in addition to being unable to adduct her left eye, she is unable to abduct her right eye. So again, that's not consistent with INO. Hence, the eye findings are not suggestive of multiple sclerosis either. Now, the presence of ascending symmetric weakness and areflexia, on the other hand, is strongly suggestive of Guillain-Barré syndrome. But how do we explain her eye findings? Well, this patient has external ophthalmoplegia, in addition to the usual symptoms of Guillain-Barré syndrome, making Miller-Fisher syndrome the most likely diagnosis. As mentioned in the previous slide, Miller-Fisher syndrome typically presents with a triad of external ophthalmoplegia, areflexia, and ataxia, and it's associated with anti-GQ1B antibodies, which is why D is the correct answer. Now, option E is incorrect because oligoclonal bands are found in the CSF of patients with multiple sclerosis. Option C is incorrect because in Guillain-Barré patients, including the variants such as Miller-Fisher syndrome, we would expect to see albuminocytologic dissociation in the cerebrospinal fluid. Recall that albuminocytologic dissociation means there's elevated protein with normal cell count. Hence, both options A and B were written as distractors, as they do not correctly describe the changes described by the term albuminocytologic dissociation. So again, the correct answer is D, anti-GQ1B antibodies. And that concludes this section.